Hi everyone, my name's Selena and welcome to my presentation. For this assignment, I chose to focus on anxiety disorders in college students, a topic that feels both personally and professionally relevant to me because it shows up consistently in my internship at a private practice setting, whether it's a sophomore overwhelmed by academic pressure, a first generation student navigating a new environment, or a client dealing with social anxiety that's interfering with their relationships. This population walks through the door regularly. Today, I'll walk you through the research. Who is at most at risk? How how anxiety prince Today I'll walk you through the sorry. Today I'll walk you through the research. Who is most at risk? How anxiety presents clinically, what the evidence says about treatment, and what we need to keep in mind around multicultural competence and ethics. I'll also tie it back to how this knowledge is shaping my actual internship work. Let's ground ourselves in the numbers first because they are significant. According to Lu, etc. All 2023, approximately 39% of college students worldwide meet criteria for an anxiety disorder. That's nearly 4 out of every 10 students. In the United States specifically, recent data shows that 35 to 36% of college students have a formal anxiety diagnosis. And when we survey college counseling clinicians, anxiety ranks as the number one presenting concern. Cited by nearly 1 in 4 professionals in their clients' primary issue. What makes this population especially vulnerable is their developmental stage. College represents a critical transition from adolescence into emerging adulthood, a period marked by identity formation, new independence, academic pressure, financial stress, and shifting social relationships. All of that happening at once creates the perfect storm for anxiety to take root and intensify. So, who within the college population carries the highest risks? Blue, etc. All identified risk factors operating across 4 levels individual, family, school, individual, family, school, and society. And that multi-layered framework is really used for our case conceptualization. At the individual level, female students show higher rates of anxiety, likely linked to biological and hormonal differences, as well as socialization patterns. Students with poor sleep, irregular diet, low self-efficiency, and introverted personality traits are also at elevated risks. At the family level, students raised in authoritarian households or those who experience family conflict, parental verbal aggression, or overprotective parenting are significantly more vulnerable. And at the broader level, students from lower socioeconomic backgrounds carry a 109% higher risk of developing anxiety disorders compared to their higher SES. Compared to their higher peers. First generation college students, students of color, and international students also face compound stressors, including accumulative stress and racial discrimination that don't always show up on a standard intake form. Now, why does anxiety actually how does anxiety actually look when it walks into our office? The most common diagnoses in this population are generalized anxiety disorder, social anxiety disorder, and panic disorder. But here's what the research consistently shows that we need to pay close attention to. Comorbid, comorbid anxiety and depression is actually the most frequent presentation in college mental health settings, not anxiety in isolation. So if you're only treating the anxiety, you may be missing half the clinical picture. There's also a really important cultural dimension to presentation. Hoffman Ann Hinton found that clients from non-Western backgrounds are far more likely to present with somatic symptoms of anxiety, things like headaches, dizziness, chest tightness, stomach pain, rather than the cognitive worry symptoms our Western assessment tools are designed to capture. If we're only looking for excessive worry and rumination, we will miss anxiety in a significant portion of our diverse clients. That's a clinical blind spot we can't afford. Let's talk about what actually works because the evidence base here is really strong. First and foremost, cognitive behavior therapy, CBT, is the gold standard. First line treatment for anxiety disorders across all major clinical guidelines. CBT works by identifying and challenging the cognitive distortions that fuel anxiety and using behavioral techniques like graduate exposure to reduce avoidance. It's structured, measurable, and adaptable to a wide range of anxiety presentations. Wang etc. al. recently conducted a randomized controlled trial evaluating group CBT specifically with college students using wearable devices to track psychological data and found significant anxiety reductions. That's exciting because it validates both the modality and the delivery format. Second, mindfulness-based interventions, particularly MBSR and MBCT, have compelling support. Zhou, etc., all conducted a meta-analysis of 11 RCTs involving nearly 1,800 college students and found that MBIs significantly reduce anxiety with an effect size of 0.35 and also reduce depression, stress, and improve sleep quality. Crucially, 8-week programs produce the strongest and most durable outcomes. And a practical note for private practice, digital tools, teletherapy, mental health apps, chatbots are increasingly valid agents, especially for clients with transportation barriers or packed schedules. Don't overlook them as part of your treatment, as part of your treatment toolkit. I want to spend meaningful time on this section because multicultural competence isn't optical. It is foundational to ethical and effective practice. Hoffman and Hinton established clearly that anxiety disorders are expressed, interpreted, and stigmatized very differently across cultural backgrounds. What looks like resistance or minimization in session might actually be a culturally appropriate response to discussing mental health. Brim found that a student's multicultural background significantly shapes their presenting anxiety concerns, including how willing they are to label their distress, seek help, or engage with treatment. For us as clinicians, this means several things. We need to routinely assess for acute, accultural, acculturative stress in our college clients, particularly first-generation students and students of color. We need to recognize somatic presentations as valid expressions of anxiety, not as medically unexplained symptoms. We need to explore family and cultural beliefs about mental health before assuming a client is resistant. And we need to continually interrogate our own cultural assumptions so we're not pathologizing experiences that are culturally normative. A few ethical points that are particularly relevant when working with this population in private practice. Number one, always, always assess for suicide. Liu et al. Are clear that anxiety disorders significantly elevate suicide risks in college students, and the link is often underestimated in clinical settings. Anxiety is not a low acuity presenting concern. Number two, be proactive and explicit about confidentiality from the very first session. Many college age clients are still navigating parental involvement, financially, emotionally, or both. And you need to establish clear expectations about what you will and won't share. That's especially true in private practice, where parents may be paying for treatment. And number three, recognize the limits of your competence. Comorbid presentations, medication needs, trauma histories, personally, personality concerns, these are common in the population. Know when to consult, collaborate, or refer. To bring it all together, this research has meaningfully deepened how I show up in my internship. Before the deep dive, I was approaching college-age clients somewhat narrowly, focused mostly on their academic stress and immediate presenting symptoms. Now, enter every intake thinking about the full ecological picture, their developmental stage, their family background, their cultural identity, their socioeconomic context, their sleep habits, their self-efficacy, that shift from symptom focus to person-centered, evidence-informed practice feels like real clinical growth. CBT gives me a structured framework I can actually implement in sessions. Mindfulness tools give me a complement that clients often find more accessible and less clinical feeling. And my cultural and ethical awareness helps ensure I'm not just applying techniques. I'm applying them thoughtfully to real human beings with complex, layered lives. The infographic I've created is designed to be a quick visual reference, something you can pull up before a session with a college-age client, whether you're in private practice, a community mental health counselor, or a school setting. Thank you for watching. I hope this was useful, and I look forward to hearing your feedback.